So basically, what I'm hoping we can do here is we can just have a conversation where we start with saying, what are the resources that are already available here for people who have a drug and alcohol or drug problem, what we think we need and how we might be able to get there. Whether the issue is space, whether the issue is funding, whether the issue is the will of the town to take on a clinic or something. So I don't really have a way to kind of moderate this. So I'm hoping that the people at Provenza who know what research are available will kind of take over in the part that they can speak to. So, in fact, why don't we start with Provenza about what you have available in this area?
Great, I'm glad to be here. I want to point out Kip Walker's in the back over there hiding. And Kip is one of our treatment professionals working very actively in this field. And Paul Dilonn is a manager for substance abuse services for the agency and is very actively involved. I thought we'd start with some statistics, if that would be helpful. You might be surprised at the scale of, and this is just treatment services. So typically our agency serves over 3,000 people a year, and last year we served almost 650 individuals who were substance abuse clients, to use that term. Currently, we have 410 open clients who are being treated for substance abuse in the agency. We also oversee a program called the I-Plan program, which is a program in partnership with Corrections and with GROP. It provides mental health counseling and substance abuse counseling and housing for folks on probation. And we're serving 35 individuals in that program, many of whom have substance abuse issues, obviously. And I know other people can speak to this, but we are also involved with the Blueprint for Health, and through that we are providing what Vermont has a hub and spoke program. The hub is in Rutland, the spoke is the outpatient services that we provide in Bennington, and I probably have these numbers wrong because they change, right? But I understand there's almost over 250 people that are being treated by area physicians for opioid replacement therapy right now. So, and our agency provides some support and some counseling as well to those folks. Last thing I'll mention is that we are running currently 10 groups between our Bennington office and our Manchester office for folks struggling with substance abuse. So, and I believe that we are scratching the surface. Clearly there are more people who could use services that we're not able to reach. There are services we'd like to provide that we can based on our funding, but it's a very large and active part of our organization. Want to see any more?
I'm Paul Dilonn, the Manager of Substance Abuse Services at UCS in Bennington. And well, I just wanted to add that, UCS provides several services to help people with substance use issues. And along with the groups, we provide individual counseling. And it's quite a process. If people need our services to call, and we work very hard at trying to identify their individual needs and identify what their individual recovery needs are. And we're working very closely with MAT providers such as Dr. Kloster, Dr. Park, Dr. King, Shaftesbury, and Mount Anthony around the medication-assisted therapy, reduction kind of programs. And so I think when I hear that there's 250 plus clients in the spoke program receiving services, that's exciting. We're starting to make a difference in trying to turn those people's lives around and meet this opioid addiction issue.
I'm Nels, I'm an addiction psychiatrist, and I've been working throughout southern Vermont and into Bennington about a year ago, I think it's been. So maybe I'll talk a little bit more about the hub and spoke as sort of a medical way of looking at things. For the one part, here in Vermont, we're actually, I think, rather fortunate because Vermont's taken a bit of a unique approach to treating addiction primarily around opioids. Rather than sort of continue kind of a piecemeal fashion with just prescribing medications, they decided to centralize this away from sort of fragmented systems that's been common in mental health and addiction for many, many decades, I would assume. So they deal with the hubs and the spokes, and I'll speak more, I think, to what we know as the hub. And then, Dr. Park, I'll leave to you the idea of the spokes, since you've been involved more intimately with that. But the idea is to have a spectrum of care for people who struggle with addiction. The hubs are a central location where we're treating people who are at the farther end of the spectrum for the illness of opiate dependency, and the spokes are sort of community physicians, so think about a wagon wheel. And right now there are spokes in, soon to be in Rutland in November, we're hoping. There's been a hub, or methadone clinic, is what these usually are, in Brattleboro and in Barry and in Burlington, as well as Northeast Kingdom too for quite some time. What's been missing is just sort of a coordination around these. So what is trying to be done, the state has been very foresighted, and probably unique in the country for this, is to turn these more into a health home. So rather than simply say doling out methadone on a daily basis or to dole out Suboxone as needed for treatment, they are bringing in resources to help meet all the health needs of the patients who are being treated there. So if I can tell you, for example, being at the hub in Brattleboro, the methadone clinic has been there for 7 years. One of the greatest additions that we had to our team there that came from the state was actually a social worker who came to help folks with their other needs, be it housing, employment, medical care. And that, I think, has been the greatest bump up in the level of care that we've been able to offer our patients at the hub. So that's it's a very important thing that's available around opiate dependency.
One thing I'll add just before we leave this area is that typically for years we've had a waiting list at United Counseling Service for people who need this kind of treatment, and through some creative use of funding and some real strong commitment on the part of our staff, we basically don't have a waiting list anymore. If you call for substance abuse treatment, you will be seen within a few days. The challenge really has to do with the availability of groups, the availability of treatment when you need it, perhaps location, but people will get evaluated. We certainly could use more creative ways to do the work. We could use more groups. We could certainly be able to provide an intensive outpatient program, which would be very helpful here, which is a program that offers basically groups every day, plus case management and individual treatment. We haven't been able to put one of those together, but we're optimistic we will soon. So waiting list is not necessarily the issue. Motivation obviously is perhaps on the part of the client, and our ability to provide a comprehensive program could improve. But things are different than 10, 15 years ago when one had to wait. Maybe it could be as long as 4, 5, 6 weeks to get in. So we try to address that issue as aggressively as we can. Clearly, though, there are folks out there who need our care who are not getting it. We know that.
What are the chances, if I may ask a question, what are the chances of a similar clinic being opened here in Bennington? Because it seems like the clinics that you mentioned are a considerable distance from here, and I don't know how people would be able to get to these places.
Yeah, that's a problem because there are enough. There's a cadre of folks who are living in Bennington who are actually traveling Route 9 over the mountain to get to Brattleboro for their treatment. Some of these have a Medicaid benefit that allows them to get a ride to transport them over there. Otherwise, I mean, it's kind of the direction I'm coming from. It's an hour 2 ways each way. It's really quite a hurdle a lot of folks don't want to put up with. The methadone clinics have been part of the conversations around setting up hubs. Have said that it requires about 150 patient population base in order to make it feasible economically for them to set up a methadone clinic. So identifying who those 150 people might be, and getting an idea for those numbers, which all those are placed. I mean, probably just 250 people are treated with Suboxone alone, which is one piece.
Yeah.
It's a little hard to extrapolate out to sort of who's hiding, who's not ready, who's waiting for them to be treated on the effective one. So I think if we had some hard numbers around that, then we might be able to entice somebody to come and set them up here.
Who do you think would be able to help you with correlating that data?
You know, there's a lot of partners in the process of setting up the hub and spoke. It's clearly the the state agency that oversees substance abuse services, plus the state Medicaid agency, and they have a master plan, if you will, which has regional methadone and opiate replacement centers throughout the state with an extended array of follow-up and outpatient services in other areas. And I think a lot of it has to do with population, where the need is. Clearly, we know, and it's pretty obvious to a lot of us, that Rutland is a hub, if you will, for substance abuse issues and crime related to it. So I think the state felt strongly that Burlington, Rutland, on the western side of the state would be where they start. We have been talking about perhaps seeing if a satellite, mobile, whatever the model might be, could be thought about for Bennington County, but I think first of all, the Rutland hub hasn't started yet, so I think they want to get going and see how they can service folks. Clearly, transportation is going to be an issue in the induction phase. In the beginning, people have to get there every day, and that is a challenge. But for some of our folks, they've been traveling an hour and a half or farther to go to Massachusetts or elsewhere to get their treatment. So the state views this as at least an improvement.
So since we're on the topic of what we have now, that's a segue to, so I'm a spoke. Okay, so there's the hub and the spoke. So remember, to be clear, the hub is primarily methadone and intensive services for those that are at, as Nels said, at the higher end or the higher intensity end of the spectrum. So one of the strategies that has been ongoing really since some legislation changes at the federal level since the early 2000s has been empowering regular family physicians, primary care physicians to treat their own patients in their own practices who struggle with substance abuse. So that's the ideal model, right? Is you stay with your medical home, you stay with your regular physician. If they're able to give you the services and have the resources provided that meet your need. So there are some people who just, their level of addiction, their level of other comorbid conditions, mental illness, etc., makes them a hub candidate. But there are definitely people, everyday people, kind of just like alcoholics and other people who are functioning in our communities but are struggling with substance abuse. So ideally, you would be able to see your own physician and do that. And so that's where people like myself come in. So it's not that Brattleboro, Rutland, Burlington are the only places to get treatment. What the state has done, which is wonderful, is that when I first started this, almost 10 years ago now, your basic was you're a provider on your own. And here in a rural community, you know, I'm in Wilmington. I'm Southwest Vermont Medical Center, Deerfield campus. I'm in Wilmington. And so my patients struggle to get drug and alcohol counseling, therapy for their mental health issues, social work, other things to kind of bring the circle of care around to them, because substance abuse is just part of the issue. Okay. So now that the state has enacted the hub and spoke and have supported the practitioners, now I have a therapist in my office 2 to 3 days a week. I have access to a social worker and other things, which is just amazing for myself and my patients. I mean, early on, I could only carry a certain amount of patients because they are high intensity. They take up a lot of visits, they take up a lot of psychological and mental energy from myself and my staff. Now, literally, I've probably almost tripled, maybe doubled the amount of patients I'm seeing since the hub and spoke and the support of the community health teams has come about. Okay, but so that's great. So the overall master plan so far has been working, and part of it is there was a concern about retention. They were losing physicians who were prescribing medication-assisted treatment through either buprenorphine or other. I think hopefully with this program they'll have retention. The next stage is going to be recruitment, because unfortunately, as much as UCS and Bennington providers are working their butts off, vast majority of my patients are coming over the mountain from Bennington, which hampers my ability to treat them, because then the distance becomes an issue. Having them come over, especially in the wintertime, becomes, so now that their capacity has increased with the addition of Dr. Kloster, hopefully some of those people will return back to their home base because it's not ideal for them to be coming to see me. I'm glad to see them, but at the same time, it's not an ideal situation. So we need more spokes just as much as we need more hubs, and in many ways, maybe the spokes might be the ideal place to centralize. Hopefully, the vast majority of care would be through spokes, because hopefully, most people are not as severe as we think they are, but we just don't know. It's a big tip of the iceberg below the water surface. We don't know what's laying there in terms of who's addicted to what. So anyway, so that's what's out there now. And hopefully, as time goes on, because the hub and spoke is relatively new, hopefully word will spread that other physicians will feel empowered. Because as a physician before this, I mean, if you're dealing with someone who you deem as someone who has a substance abuse issue, who you wonder about, and you sit there and go, well, I have nothing to offer them, and I say send them to the methadone clinic in Brattleboro or send them to the upcoming hub in Rutland, but I'm sending them out of my practice, I'm sending them out of my community, and that's not ideal. So now, hopefully, more and more physicians will feel confident with the additional support to say, oh, I can treat my patient, because just like diabetes, just like hypertension, their chronic illness, this is a chronic illness that affects all of their other illnesses. Probably the first one. If you're looking for drugs every other day, you're not treating your diabetes, you're not treating your hypertension. This is a health problem that has to be addressed so that the rest of the health problems can be addressed. So that's kind of where we are, and hopefully where we're moving, in my opinion.
And I'm also going to ask people to, if you don't mind, introduce yourself,
Sorry.
especially because Kat.
Okay. So my name is Peter Park. I'm a family physician, work for Southwestern Vermont Medical Center. I'm at the Deerfield Valley Health Center campus out in Wilmington, Vermont, towards Mount Snow.
And for you guys, I think we've talked about some treatment, but I think that for Turning Point, a lot of this is maintenance.
Right. My name is Joan Walsh, and I'm the director of Turning Point Center, and been in this position about a year. Been with Turning Point for two and a half years. So one of the things that we feel very strongly about, first of all, the work that all of you do is it's top-notch. It's what needs to be done. And it is a big problem, as we all know, the substance abuse in Bennington and any place else that we might go. But Turning Point Center, what we offer is we offer some place for people who are in recovery, who are trying to turn their lives around, a safe place to come be with other people in recovery. And that's key. You know, if I was trying to recover from substance abuse and I went to a meeting and I went to see my counselor and maybe pick up another meeting, now what? Where am I going to go? My family's all angry with me. They don't want me, that kind of thing. So Turning Point really does provide this safe place for people to be. And I know that the Turning Point in Bennington has gone through a lot of rough years, and we have worked very hard in the last couple of years to turn all of that around. So we truly are a safe place right now. And what we offer, besides them to be able to come in and be with other peers, we are a peer-to-peer service. We are not professionals. We pretty much are there. For some of the 12-step programs, we do rent space to them. We are not affiliated with them. We are there for people in all pathways to their own recovery. And what we have, there's AA, NA, Al-Anon, there's Alateen meetings that are held at our center. We also do our own facilitating of things such as making recovery easier. It's a 6-week program for people that are considering going into a 12-step program, or perhaps they tried it and they didn't like something about it. So we talk about the components, the sponsorship, the spirituality, all of that. It's ongoing, they can come in at any point. We have recovery coaching. When people say, well, how is coaching different than a counselor or a sponsor? And basically what a coach does is we meet them where they're at. We believe that they all have their own answers within themselves, but they can't get in touch with it quite often, like a lot of us can't at certain times in our lives. So we say, okay, this is where you're at, where would you like to be? And then we work with them as they move themselves towards any area of their life that they would like to change. Bottom line, we are adding some new programs soon, but again, please remember we're not treatment and we know it. But we are a real, I believe, a very strong addition to what you're doing, and we can help them. And I'm very, very happy, by the way, and I thank you for including me in this particular program this morning.
One other thing, by the way, I should have said before this kind of table setting, and Chief Doucette may want to address this a bit, but I just wanted to kind of point out, I think people here in this room know this, but for people who are watching, the reason that we're looking at this, of course, is that, Chief Doucette and the law enforcement in this area does a good job of finding people who are selling drugs, putting a stop to it as best they can. But also, I think that people need to remember that these are our friends, our neighbors, family members. These are people who, if we can treat their addiction, probably won't be in any legal trouble, or won't be burglarizing a house, or won't be driving around a corner and driving an SUV into somebody's house. So I just wanted to make sure that we address the fact that the reason we're talking about this treatment is, there's more to this than just the law enforcement part. That's the part that, of course, easily gets in the paper, but we can't just arrest our way out of this situation. We have to treat these people. And I don't know if that's something you want to elaborate on a little bit.
First of all, I was pleased to be invited to this. I realize that I am not in the same line of work as the rest of you, nor is my staff. We, in cooperation with many other law enforcement agencies in Bennington County and the Bennington County State's Attorney's Office, have been successful in locating, identifying, and apprehending drug offenders. A lot of these people, as we full well know, are in this business to support their own habits. They receive their supply of narcotics, they take their cut, they sell the rest to pay for what they're going to use. Some people are in this, it's a business, clearly a business. Similar to UCS or Walmart or whatever, it's a business. You're making money, but they think that they're trying to help their friends but they're constantly gaining new business. That's a huge problem for us. And in the law enforcement world, we go out, we identify, locate, target, develop our probable cause, we make our arrest, the state's attorney's office prosecutes these people, and then they get sentenced. And I firmly believe that part of their sentence needs to be treatment for their own addictions, because that's what a lot of these people have. And then it's not just that. I spent some time talking with Joan, and we often forget about the recovery piece. That needs to be there as well, because if these people don't have something solid in their lives, they're going back to what they know, which is selling dope, using dope, and making their life what they think is a lot easier. And that's a problem for us. Oftentimes what happens is we go out, we make drug arrests, and then I get the phone calls. Well, my family member is addicted to drugs and you need to help. Unfortunately, that's not what we do. And I feel badly saying that, but it's the truth. And it's not that we don't want to help people. We'll take all of your information all day long. We'll go out and we'll develop criminal cases, because that's what we're supposed to be doing. We have really changed the attitudes of people in this community with the last couple of drug sweeps and working with the drug task force and the state police and other agencies. And we've done a lot of positive work. But now, and we're going to continue to do that work. There's no doubt about it. But now what we need is all of you to make sure that we're getting these offenders the proper treatment that they need and making them good members of our community. They can go off to treatment, receive their treatment, and come back to the same problems that they left when they began their treatment. We have to find a way to make these people solid members of our community. We have to help them recover and become good citizens. We want people to be good citizens. There are so many great stories that come out of 204 and 206 Depot Street, the Bennington School, where we've had delinquent juveniles. There are so many positive stories. The senator and I talked about this. No one wants to come out and say, I went to 204 Depot Street when I was younger. No one's going to come out and say, I received treatment from UCS and now I'm a manager at Walmart or whatever the deal is. People don't want to say that. That's what we really need to hear to promote other people to get involved in treatment and recovery programs. And that's something that the police can't do. That's something that doctors and therapists and clinicians, that's what you all need to do to promote these people, bring them back to our community, get them involved. We can go to meetings all day long and sit there with other people that have been involved in narcotics use, and that's okay, but at the same time, we have to get them to seek employment. We have to get them to be good members of our community. The other problems that we face today is a lot of the employers in Bennington, some of the bigger ones, are drug testing. And if you fail the drug test, you don't get the job, or you don't get the position. So we need people to receive treatment and be clean. And I'm not opposed to, and I know this is a huge controversial topic, I'm not opposed to putting a hub, that's what we're going to call it, Dr. Park, we're to put a hub here in Bennington so that our people aren't traveling over the mountain and going to Wilmington or Brattleboro or eventually up to Rutland. This is a problem for me. You're going to go and receive your Suboxone treatment, or you're going to get your methadone, and then you're going to drive back to Bennington? That is absolutely ridiculous. Because now we're driving under the influence. And it just creates a problem for us. I'm not opposed to people getting treatment, but what ends up happening is, and I'm just, from the research that I did prior to today and what I've done for the last 24 years, it's a problem. Because this drug issue creates so many more problems than just illegal sales of narcotics and illegal use of narcotics. We've got burglaries, we have retail thefts, not to dwell on Walmart and Home Depot, big box stores, people don't like them. But the bottom line is, those are the places that are getting hit hard, people pushing their shopping carts out the front door with thousands of dollars worth of tools, and they take them and trade them for illegal substances. These are the other problems that the drug issues bring to our community. And sometimes, going off the track just a little bit, sometimes we invite that with the system that we currently have in place. We allow people to come into the community, they get on public assistance, their apartments are paid for, they're not working, and so in a sense, we promote that. The bigger problem that I see, in speaking with the senator and Stu Hurd and Dan Monks and others, is we need to find a way for the entire state of Vermont to get on board with what the successes have been in Bennington County, over in Wyndham County, over in Springfield, with the drug sweeps, identify targets, get people treatment, help these people, help them recover, and Senator Sears, I know, has worked diligently at trying to make this happen statewide. So whether we're the model or, clearly the southern part of Vermont has not been forgotten in the last 6 or 8 months with all the drug activity that we've seen. This problem has existed throughout the entire state, not just Bennington. Bennington's a great community. We just decided that we are going to grab the bull by the horns and take some type of action to help combat this. We can't just keep having people sell drugs. We can't have Dr. Park be busy with his practice in Wilmington and not be able to treat people here in Bennington. We need to educate our local doctors with this type of program and have them. If you have a general family practice like Dr. Park, and the doctor that runs that practice or doctors are willing to receive training and be able to treat some of these people, that's what we need to do in conjunction with United Counseling Service, in conjunction with people that are going to recover at Turning Point. We're not going to solve this problem overnight. We need to take action and work collectively to succeed. And I firmly believe that. And we in the police department are going to continue to battle what we see as the drug problem, but the drug problem that you all see is in a different light. And we all need to work collectively. And I think that is how we would be able to rectify some of the issues. I'm not going to say solve the problem, because this is very difficult to solve. And I don't think we're ever going to really solve the issue of drugs. But we can push back, we can fight, and we can save people. That's what we need to do. Save them and make them good members of our community.
So, I was going to say, that's a good, probably a good second point to say. So what do we need here? What, if we're being handed the problem, so to speak, treating the drug problem in Bennington County?
I'd like to, first of all, thank the chief for his work on this. It was 2 years ago this month that he and I began discussions about the problems in Bennington with substance abuse. And that led to the bill that established the gang task force and resulted in these sweeps around the state. And it was further discussion with other chiefs, with the state police and others about this problem. But one of the things that I think is lacking, and that, with all due respect to everybody, 19 months ago, I was up in Rutland discussing the hub and spoke, and it was going to happen next week. Unfortunately, government works very slow, and at the same time, we've now come, we know that it costs about $95,000 a year to support a heroin habit in Rutland. I don't know what it costs in Bennington. I wouldn't imagine it's much different. You think about $95,000 a year and how much crime has to go on to support that $95,000 a year. So here's one of the things that, and I've talked with the governor's office about this, I think that it's time to move to treatment on demand. And by that I mean, you get somebody who's been arrested in these sweeps, they go to the judge. That is an opportunity when maybe they've woken up, but we don't have any screening at the courthouse. Ralph has screening up at UCS if somebody comes to him. It seems to me it's time to look at that screening device, and that's some legislation that we're trying to put together right now that would require the screening to take place so that the state's attorney, maybe the defense attorney, the judge would know what they're dealing with before they release them on bail, before they send them to jail. What are we dealing with here? Are we dealing with somebody from New York City who's come up here on a regular run to make a lot of money, or are we dealing with somebody who has real addiction problems? And then go from there. I mean, if you went to the emergency room and you were saying, I've got chest pains, they wouldn't open you up and do open heart surgery before they ran a few tests. But that's what we're asked to do every day in court. And Bob, I mean, you know what it's like. You're standing there, you've got this 13, how many cases did we have last week?
It's 23.
23 cases in front of you. I'm sure they're all 23 individuals and with much different stories, much different issues. So in determining how to deal with those 23, it makes sense to me to try to do an evaluation. Here's the problem. Some states' attorneys will fight that. Other states' attorneys will embrace it. Some defense attorneys will fight it because they don't want anything that's information used against their client because they're presumed innocent. So, it does have some drawbacks, but that's one thing we're going to be trying to deal with, is to get that treatment. I mean, I don't know of any time when somebody's more amenable to treatment when they're until they're standing before a judge who now has their freedom under their control. I think that's a great time to start to make some interventions. It would certainly help you. On the Suboxone side, I think it's a great drug if managed properly. The problem is it's one of the most abused drugs. As a matter of fact, the prisons, of all the drugs that are used in prison, Suboxone is number one, far and above any other drug that's being used illegally. So that needs to be managed properly, and that takes the hub and spoke and the case managers for Dr. Parks and any other doctor. I don't know how you can do it without that. Those are some of the challenges that I see ahead in the next legislative session. But we're going to push this heavily. The governor's committed, the staff are committed. to dealing with this problem. You know, we're not the only state in this shape. I talked to some legislators from New Hampshire. Manchester, New Hampshire is under the same, if not greater, pressure than Rutland and some of the other cities in Vermont. It's not just Vermont, it's not just Bennington. It's all over where the heroin has taken over because it's cheap and it's highly addictive.
You know, if I could jump in, there are a few pockets in the state where they're doing some innovative things, and certainly it's worth more discussion, but I know in Windham County and perhaps up in Burlington, there are programs where after arrest, prior to sentencing, the individual's offered the opportunity to get involved in treatment, and if successful, perhaps the sentencing will be reduced or delayed or whatever might happen. And there's a program called the Sparrow Program over in Windham County that does that. We would like to do that. It takes a lot of planning and groundwork and obviously a little more expansion in our funding in order to be able to do that. But I think, I totally agree, Dick, that's when people are amenable. We also know, however, somebody struggling with substance abuse will say yes, but perhaps be harder to deliver yes when the addiction takes over. So we know that we'll have perhaps some involuntary yeses, but anything to start. And I know in some other parts of the state they're trying to intervene right then, hopefully with reduced sentences if the individual will agree to get involved with counseling and substance abuse treatment. And to your point, I completely agree as well that we're trying, you know, ideally you look at lifestyle. People are living in the same neighborhood with the same friends, and perhaps they're not working, perhaps they're just hanging around with friends who are not working. So in addition to treatment, we've got to figure out a way to get folks to move away from the habitual kinds of patterns that got them into trouble in the first place. We know in our corrections program, people get out of jail, they're on probation, they're involved in our treatment program, but unless they're also involved in some pro-social things, looking for a job, doing something positive, they're still back in the environment that got them into trouble in the first place. So that's a tougher nut to crack, of course, because we're talking about getting people out of their former lifestyle and out of the neighborhood where their friends are. But you know, it requires looking at the social service part of the issues that addicted people have. And I think that we try and do that in our I-Plan program. We can offer housing through our partnership with Brock, but it's a tough go to get people out of lifelong habits and patterns and neighborhoods. But I think we do need to look at the whole person and not just their treatment. They have social service issues, vocational issues, etc.
And I just wanted to add to what Dick and Ralph were saying. There are programs like drug court programs in other counties. I believe they just started the first DUI court, kind of drug court program in White River Junction for DUI offenders, to have somebody right there to do the assessment and help people get a case manager to start that whole process. And you know, I was going back to your email about, you know, what's available. And I think sometimes the average person, the citizen, doesn't understand the amount of resources that go into supporting people with substance use problems. You have your diversion programs, I think, in almost every county. You have our I-Plan, the DOC, the federal probation. We have Brock, we have CRASH, and if you don't know what CRASH is, that's the Drinking, Driving, Rehabilitation Program for the state of Vermont, which we offer at UCS. That program is an education program for DUI offenders. You wouldn't believe how many people start that process with a DUI and find out that they have substance use issues and problems, and that starts the treatment. And so, and the schools. You know, so there are so many resources and programs going around in Bennington that are involved in treating someone with substance use issues. And everybody's recovery is individualized, and that's what makes it very challenging as well. But I think we continue to get the word out, how many organizations and agencies and what resources we have available in this county is important for everyone to know, because it's not just UCS, it's not just the hub and spoke. It's not just pubic morphine. lots of organizations are involved in helping these people recover. The police department is huge. It may sound, criminal, it may be punitive, but so many people come from the criminal justice system to get help with ISAP through the DOC and other programs that lead to other kinds of therapy and treatment that aren't even substance use related. And the Turning Point is an entity known throughout the state. It's not, most people probably don't realize that Turning Point is huge and a great program. And you have a great mentoring program. And then you have your 12-step programs, and your AA and your NA. And so there's lots that goes into the recovery and treating people. And then there's the referral process. People come to UCS, they get assessed, they get evaluated. It's like, you know what? You need something more. Now we're sending maybe to residential treatment facilities. We have Brattleboro, Serenity House, Maple Leaf. So it's a process, and it's a very comprehensive process, and you really do need to be very holistic and looking at everything that goes into treating one person. Maybe that's why it costs so much to treat one person with an opiate dependency disorder, because you look at all the people, all the players.
The $95,000 is what it costs to keep the heroin habit going,
Yeah.
not treatment.
Okay.
It's for the family.
Before the treatment even starts, it's
Right.
it's the theft, it's the drug sales, it's whatever they can do to get that $95,000 to stick it into their arm.
So I do think that we need more tools in the toolbox when people are arrested, for sure. I think that we need more counselors available to physicians so that they're willing to serve and provide opiate replacement treatment to these folks. A lot of docs are not willing to serve that population or provide that treatment to their population because of the support needed in order to do it successfully. And the SPOKE program doesn't go far enough. So clearly, we need more counselors like Kip and others who are willing and able to go in and work with a physician who's been trained to prescribe that therapy for their own patient load. More may be willing if the resources and the backup was there. We know that. But I do think that at arrest, we ought to have more options. We almost need a crash program for folks who are addicted, who get in trouble, and if they would go to maybe they had to, but if they were involved in that program, perhaps the consequences could be mitigated somewhat. There's got to be a motivator there.
I'm often reminded of that adage, it takes a village to raise a child, which originally came from education. And too many of us are working in our own sort of individual silos, their own sort of perspective, whether it's sort of treatment or even within treatment, recovery-oriented centers, 12-step programs, talk therapies, medication-assisted therapies like Suboxone and methadone. So I think one of the things we really need is more sort of shared knowledge across our various silos, and maybe that will help us sort of develop a little bit of sort of empathy and understanding of other people's approaches. I think I've talked to parole officers, I've talked to lawyers, I've talked like Amelia, I've talked to you at the Sunrise Resource Center there. The trouble is there's no real network to keep us talking to each other. And so we all then fall back into our own little silo, and then people fall between the cracks. So I don't know if something's being drug tested from the PO necessarily, just something bad happens. They don't know if they're showing up for my program and doing things like they're supposed to. I don't always know if they fall in line up counseling with their therapist at UCS. So somehow there's got to be some kind of linkages going on here, but I think it's really the most important thing here. We don't know how many resources we necessarily need, because everybody thinks, my issue is the biggest issue. Addiction is the greatest problem in the state. Let's send half the healthcare budget to what I'm doing. I think about the right amount of coordination right now. We don't even know how much we need. And that's what's been a very frustrating piece for me. And I got to say, sensationalizing this as a criminal issue, I think is a disservice to a lot of people. I think if people understood this more as a treatment issue, we might see better results down the road. I think pictures of classrooms from arrests, those haunt people down the road. Most of the people that I've worked with, while there are some exceptions, they became addicts first and criminals second. So I think that's a very important piece for us to remember as well. But I agree, these people coming to New York City and bringing stuff, I'd like to personally handcuff them myself.
Raise your right hand.
We're being pressured like like you said, you get a methadone clinic, get someone to go there, get on methadone, now they're driving. The marijuana stuff coming up now. It's putting pressure on the schools and the diversion programs. And once a month, I'm fortunate enough to meet with a group of people at the high school, the South Shire Coalition, who are attended by the public sector, the private sector, the community colleges, church, and we're already trying to prepare how we're going to address the increase in marijuana use now, because of all the talk around, the decriminalization and now the legalization. So it puts pressure. Sometimes we aren't thinking about the pressure something like that is putting on at this level, and we're already starting to gear up. How are we going to be met with that challenge? So I hear what you're saying about the pressure. Sometimes we think we're doing the right thing, and we are, but it impacts us somewhere else.
Whatever. I didn't want to let that go. I mean, not to go into a long discussion about it. If somebody's on an appropriate dose of Suboxone or methadone, they should not be in withdrawal. They should also not appear to be under the influence, be mentally clouded, nodding out, uncoordinated, those sorts of things. It's always a difficult dialogue with physicians and patients around prescribing these sorts of substances that often we don't have the so-called round-the-clock picture. But just the idea is not like the HBO special methadonia, where folks that get the medication come home and sleep all day. And that's not the way it's supposed to work.
Right, no, and I understand that. One of the pieces in that is, and this is controversial because, quite honestly, one of the big fears years ago when we started talking about a hub here in Bennington was that we were going to draw people from other parts of the state that would want to take up residency here. Where our big fear is to bring people in from other states, because we're not here to treat those people. And I don't want to sound harsh. We're here to help our residents, the people that live here in this state. We don't want to bring in people from other locations and start helping them. This program should be, Senator, for Vermont residents who have an addiction problem. I don't think we should start bringing people, and I think it needs to be closely monitored. We spoke about this, the senator and I yesterday did. There needs to be case management for somebody like Dr. Parks, who he might need some assistance perhaps from the state, where we can have an extra employee in his office that can help manage. Maybe Dr. Parks doesn't need to see Paul Doucette when Paul Doucette's on Suboxone. Maybe the case manager can see Paul Doucette and take a look and say, okay, bring your Suboxone in the blister pack. I want to make sure that you have what you're supposed to have still in this blister pack and it's not disappearing. Because that's what we have. When you get it in the bottle, next thing you know, people are selling it. Suboxone is highly abused. We know that. Methadone is highly abused. So we have to try to weed out the people that really want our help, and we need to monitor them closely. Not 60 days out, not 90 days out. We need to see them, as Dr. Park said, on a regular basis. It takes up a lot of time. Now, I feel for the physicians that want to get involved in the HUB program, because what happens is, quite honestly, now you're sitting in a waiting room as someone who's a little bit older who might have bronchitis or whatever, and you're sitting in a waiting room waiting to be seen by your family physician, and now we have 3 people in there that, may appear to be jonesing, may have other issues. So it's hard for someone with a family practice to take this on. I give Dr. Parks credit for that. Good job. But the bottom line is we have to find a way to get these people into his office, see the case manager, how's it going, what's going on, make the notes, check the pill count, send them out. We need to monitor these people. That's what needs to happen. That's the only way we can use drugs to treat a drug issue, is to monitor it closely. We don't want to create more issues by bringing the HUB program into Bennington, and next thing you know, people are selling their drugs. Does that make sense?
That makes sense. It's not unique to addiction either. I mean, if somebody came with hypertension, high blood pressure, diabetes, there'd be an amount of education and monitoring on that as well. It's just a little bit different because there's no street value for lysenko. So there's a different sort of skill set.
We both take that. It's good.
And you got to stand out. Yeah.
There's street value to pregnancy on that.
So, if I could just step in just quickly, 2 things I want to just, first is, I'm in court a lot of times I hear them talking about somebody's in there, they have some kind of drug problem, which is leading to criminal behavior, and they say, well, we will release you if you can get it vetted here. So the first thing is, do we need another inpatient treatment facility in this area? And the second thing is that I appreciate you guys all being here. We are getting close to 9 o'clock, so after that, I'm hoping that if there's anything else that you guys want to get to, we can get to that, because I do appreciate you taking the time, and I don't want to keep you here too much longer than.
Can I respond to that?
Please.
You know, that is a difficult challenge. And one of the things that we hope to find out more about is how the Affordable Care Act will affect the corrections population. There may be some opportunities there for the creation of more beds. They may not, obviously, you can't lock somebody up and then continue to have anybody who's in prison is automatically 100% general fund, even their health care under current law. Now, how that changes under the Affordable Care Act, we need to find out more. My assumption is that if it's a private group that operates beds, they will continue to be able to get Medicaid, but more people will be insured and then have that treatment. So I think there's an opportunity here to look at that as increasing the number of residential beds in the state. That's part of the frustration that many people face, is that they go away for 28 days or whatever that period is, come back, and then what services are available, or they slip back. I don't think there's anybody with an addiction problem that doesn't take a step backwards as well as steps forward. And it's how we deal with those steps backwards that are key to the long-term success. So I think that there are some opportunities where the Corrections Oversight Committee is meeting on Tuesday, and we're hoping to have a presentation from Vermont Health Connect on how the Affordable Care Act will impact the very folks that we're talking about right now.
And quickly, as a weather report, do you get the sense that the legislature, members of the legislature, get the idea that this drug problem is as serious as we see it here? Is there any resistance from the legislature? I mean, I know they have a lot of things to balance, but
There's resistance to everything in some parts of the legislature. So I don't think there's anything you could say, well, there's 100% support. I think generally, the vast majority of legislators in all three parties are determined to try to deal with this substance abuse problem that Vermont faces in a rational way. And now there's some who look at it differently. And it would be arguments over, for example, in the screening program, arguments over individual rights. Does the state prosecutor have a way to know what they're dealing with? Should the information be shared? The Sparrow project that Ralph mentioned, the information is not shared with the state's attorney. The state's attorney makes an agreement to allow the person to enter into it, but the defense attorney has the evaluation and so forth. They can't be used against them. Obviously, if they fail the program, then they're back to square one. In Burlington, there's a rapid intervention program that they don't even get to the court. Bennington used to have a drug court. We lost that drug court. The state's attorney at the time didn't agree with the policy, and so that changed. But back when they did have a drug court, there was an evaluation that was done by UCS. I think anybody with a DUI or any drug-related crime was evaluated. And that's the type of thing that we're looking at. And I think there's, you need to understand what you're dealing with before you decide to send them away for 10 years. They're not to say that some of the folks don't need to be sent away for a long period of time, but before we do it, we ought to know why they're doing it and what we're dealing with.
And again, we're getting close to 9, so is there?
I'd like to jump in if I could. Maybe back to what we were talking about, Sebastian. There is a documentary that's being shown throughout Vermont, and it is coming to Bennington the 9th of November, and it will be at the Arts Center. And after that, we're hoping to put together a forum for the community to come in and share their thoughts. I just wanted to put that out there. A lot of it, the turning points are the ones that are kind of behind this. This was filmed in, we didn't film it, Beth O'Brien did, in St. Albans. So it is an excellent film to see. And we'll be putting out more information as we get a little closer to it.
The title's Hungry Heart.
Hungry Hearts, yes, I'm sorry.
I
So
guess
I just wanted to add to what the chief had said, so thank you. So what the Hub and Spoke has done is put case management in my office. So basically, I just would say, continue with the Hub and Spoke, keep pushing that, keep making sure you know that's protected. I don't know at the highest level, in terms of planning, at the administrative level, how much law enforcement and the health community come together in meeting and talking about the Hub and Spoke, but I think as today is an example of having both arms kind of understand where each are coming from is important. Myself and Nels have gone to a learning collaborative that the Hub and the blueprint the Hub and Spoke puts forth, and we've learned a great deal about being, you know, what we're doing right, what things need to be tightened up, the problems. Our last learning collaborative was with probation officers and law enforcement and people from corrections, and so it's a great sharing of each other's perspective, but it also showed kind of where we differ in terms of the lights at which we see this through. I think education on both ends is important, and communication, you know, coming out of that definitely was my vow to, if I know anyone is involved with corrections, that I'm going to make a greater effort to talk to their PO and vice versa. But at the same time, you know, obviously law enforcement has a very specific view of this problem as well. So just hopefully as we move forward, hopefully it'll be together so both sides are educated about, you know, for us health professionals, it's the deep, dark side of things, darker than we even imagine. And on the other side is the idea that there are success stories that, you know, the vast majority of people on Suboxone, okay, I don't want to misspeak because I don't know that for sure, but many people on MAT are doing they're working, they're doing their thing, it is a success. And so when we all know that Suboxone is one of the most abused drugs in corrections as well as other places, doesn't mean that the program as a whole is a failure. You know, national statistics have shown, granted in small amounts, that where MAT programs have come about, that there's harm reduction, there is reduction of crime in all the peripherals. So it is a worthy goal, it's a worthy program, it just needs to be done right. And so that's what we want to all work for, not to cut the legs out from under it.
I just want to piggyback on that, Peter. The statistics, particularly on methadone treatment, as far as for dollars spent, the payback around issues of criminality and productivity and then healthcare costs. About a $4 for $1 payback on methadone, and about a $7 for $1 payback for substance treatment in general. So that's money well spent. Comes out unfortunately much better than other sort of eradication or wiping out efforts, that sort of thing. So I think it's still a good place to put the money.
And to go along with that, you are 100% correct that, you know, we only hear about the bad parts of our drug treatment programs. We never hear about the success stories. You're not going to get the people to get on TV and say, I was on Suboxone for 3 years and look at me now. It's just not going to happen. So, and I think, you know, in the law enforcement world, you're right. We're so focused on getting the bad guy and getting the drugs that sometimes we do have to take a step back. I agree with you there. The one last piece, Patrick, that I have is with all of this being said, with treatment and different types of programs, you know, the one thing that bothers me the most is the youth in our communities, statewide, nationwide. We need to remember that they have a long future ahead of them. And what we're doing now to curb or prevent some of the issues that we're currently seeing will better their lives. And we need to continue to think about the youth and the younger people in our communities to make sure that we are properly treating the people that we're seeing now. It's a learned behavior. We know that. You know, whether you saw your parents abuse prescription drugs, when you see your mom feeling a little down and out, so she goes to the medicine cabinet. You have a bad day at school, so you go to the medicine cabinet. You know, it's just a revolving circle. And it's bothersome to me. I just want to share that with you, that we really need to find solutions, get people treatment, help people recover, so that our future generations will be successful in life and not have all the issues to worry about that we're currently seeing now.
Yes.
Completely agree. We need to do more prevention. You know, in our world, mental health centers, we're treatment, and it's hard to get support, we figure out ways. We do need to get to the schools more. We do need to do more prevention and try and get upstream from this issue. And finally, I'll just say again, I really think we need to be able to offer more after arrest. We need more capacity so that we can offer it and deliver. But I think overall, we have tried hard to expand what we're doing, and we're seeing more folks in various forms of treatment and various programs than we ever have before. And yet we're having this meeting on the drug problem in our community. I mean, that's a testament to how large the problem is and how we're struggling to figure out a way to stay on top of it.
I'm sorry.
Just real last thing. So not to see me being here as, there are definitely providers in Bennington, so I just want to be specific that there are spokes in Bennington aside from UCS, so I didn't want it to come off as if there weren't any doctors in the community who are doing this important work. They just weren't able to be here.
And I think one last early question here is, so if somebody is watching this, reading about it, and they do have a drug problem, family member, what would you guys recommend is the first step to say, if somebody's saying, okay, where do I go to say, where do I need to go? Do I need to go to a physician? Do I need to go to UCS? People who do need help, what would be their first action point?
Clearly, they should call us.
Start first. If you're a Bennington person, try to get treatment in Bennington because travel becomes a barrier to success. And now UCS is well equipped to do that, but yeah, that's the first place.
And I would put in a pitch for Turning Point as the place to get support, education around issues, whether it's a family member or an individual. And as I said, call our organization where we will be able to help an individual figure out the extent of the problem and what we might be able to do. Certainly call. We know there's a stigma associated with this, which is why sometimes people don't call. If your stomach is bothering you, you'll call your doc. But if you think you might have a drinking problem, you may not call us. So talk to Turning Point, call our agency. We have counselors available. We can help figure it out together.
So I'm hoping if everybody here found that this was somewhat productive, maybe we can do this again in 6 months or a year, or whatever makes sense, and kind of take the temperature and see what's going on then.
Thank you, Beth.
Thank you.
Thank you.
Thank you. Good.